Hey, welcome back to week 7 of the Pharmacy Technician course brought to you by the Fun Pharm Tech. This is going to be the last PowerPoint of the course before the practice exams. Um, so what we're going to be going over today is going to be the healthcare in the United States, technology and automation, and a comprehensive review. So the healthcare of the United States is found on page 205 to 211. Technology and automation are found on page 217 to 226. And the comprehensive review is just going to be with me, not in the book. Now, the healthcare of the United States, it's always changing, but there are a few things that will basically remain the same. And for the test that you're taking, it will cover just the things that we cover in class. So you don't have to worry about that. All right, so healthcare in the United States. All right, so the healthcare is a major industry employing millions of healthcare providers and support personnel. In the United States, healthcare is provided through a mixture of public and private plans. Consequently, the financing and the delivery of healthcare is complex. With technological advances in diagnosis and treatment, individuals are healthier, and even those with chronic conditions have enhanced quality of life and longevity. The promise of affordability and access to modern healthcare has figured prominently in the presidential campaigns for the last couple of decades. One of the nation's healthcare dollar, approximately 14% is paid out of pocket, with the remainder coming from a mix of public and private funds. On average, each person spent approximately $808 of personal funds a year to pay for medicinal needs prior to reaching a specific annual deductible. These are cost-sharing dollars because the consumer shares the cost of treatment with the insurer. A person's out-of-pocket expense depends on the type of insurance or the government program in which he or she is enrolled. In 2001, annual prescription drug expenses per person were $497. This is a small expense compared to the total $5,039 spent on all health services. On average, consumers spent over $100 from personal funds for prescription drugs because insurance plans tend to require the consumer to share these costs. Nearly 85% of the 285.2 million Americans had some type of insurance in 2000. The primary health insurance for the U.S. population in 2000 was 24.2% funded by the U.S. government, 72.4% funded by any private plan, and 14% did not have any health insurance. Now, as we know, this has changed, but this is not going to be, from my experience and learning, this is not going to be covered on the test. This is just good to know for you information. I will highlight the parts that I do think will be on the test, but it's still good to know all of this other information. The largest share of public health expenditures are for government's two largest healthcare programs, Medicare and Medicaid programs. Now, like I said, those are going to be important to know. So Medicare and Medicaid programs. We are going to go over what those are in case you are not aware. Health care for the uninsured and adequate coverage for the underinsured are significant policy issues. Although many people have health insurance, the United States Census Bureau reports that approximately 14% of the population is without health insurance coverage. Surprisingly, these are not necessarily the poor and unemployed. In 2000, the employment status of uninsured individuals from the age of 18 to 64 was 23.6% did not work, 20.7% worked part-time, and 15.4% worked full-time. There are 38.7 million individuals without health insurance. Approximately one-fourth of the U.S. population will lose health insurance coverage for some period over the next 2 years. And if there's anybody out there that watches this video that wants to go ahead and let me know what those values are, I'll go ahead and make those changes to the slide. All right, so Medicare. Medicare is the federal health care program for the elderly and disabled. As part of the Social Security Amendments of 1965, the Medicare legislation established a health insurance program for aged people to complement the retirement, survivors, and disability insurance benefits under Title II of the Social Security Act. So, something that's important to know is Medicare is for the elderly and disabled. All right, and the way that I like to think about that is care. You care for the elderly and disabled. You care for them. So if you see your grandma or grandpa or struggling, you help them. You care for them. And if you have someone that you're close to or just a random stranger that you see maybe disabled, you care for them as well. In 1973, other groups became eligible for Medicare benefits. Persons who are entitled to Social Security or Railroad retirement disability benefits for at least 24 months, persons with end-stage renal disease, or ESRD, requiring continuing dialysis or kidney transplant, and certain otherwise non-covered age persons who elect to buy into Medicare. So you are able to buy into Medicare. But like I said, I think it's important just if you kind of group them together as disabled or elderly. Today, Medicare is the nation's largest health insurance program. The program is administered by the Center for Medicare and Medicaid Services. Medicare consists of two parts, Medicare Part A and Medicare Part B. These are also going to be important to know what they are. In 2002, about 40.4 million persons were enrolled in Part A and 38.4 million were enrolled in optional Part B. Medicare Part C was established by the Balanced Budget Act of 1997. So Part C is also going to be important to know. All right, so what is Medicare Part A? Medicare Part A is hospital insurance. It provides coverage with no premium cost for inpatient hospital services, skilled nursing facilities, home health services, and hospice cares to all persons eligible for Medicare. This part of Medicare is financed primarily through a mandatory payroll deduction, FICA tax. Almost all employees and self-employed individuals in the U.S. work in employment covered by the Medicare program and pay taxes to support the cost of benefits for aged and disabled beneficiaries. So our paychecks, there's taxes that come out of our paychecks, and there is a percentage of those taxes that go to help pay for Part A of Medicare. Cost sharing is required. For hospital care, the beneficiary's payment share includes an annual deductible. This covers the beneficiary part of the first 60 days of each spell of inpatient hospital care. If continued, inpatient care is needed beyond the 60 days. Additional coinsurance payments are required through the 90th day of a benefit period. So Medicare Part B. Supplementary Medical Insurance, SMI. This assists in paying for the cost of physician services, outpatient hospital services, medical equipment and supplies, and some of the other health services and supplies. That's going to be important. So medical equipment and supplies are covered under Part B of Medicare. Part B is financed through premium payment, which is usually deducted from the monthly Social Security benefit checks, and through contributions from general revenue of the U.S. Treasury. Medicare Part B. Benefits may also be bought for persons by a third party directly paying the premium on behalf of the enrollee. beneficiary premiums are currently set at a level that covers 25% of the average expenditures for aged beneficiaries. The beneficiary's payment share includes one annual deductible, the monthly premiums and payments. These cost-sharing contributions are required of the beneficiaries for Part B services. For ESRD patients, Medicare Part B covers kidney dialysis and physician charges incurred by the patient and donor during the transplant and follow-up care. So I think that would be another good thing to know is Medicare Part B covers kidney dialysis and physician charges. Medicare Part C. The Medicare Advantage program, previously known as Medicare Plus Choice, now as Medicare Part C, began in January 1999. As part of the program, Medicare beneficiaries who have both Part A and Part B can choose to get their benefits through a variety of risk-based plans. The primary Medicare Advantage plans are 1. Coordinated care plans, which include health maintenance organizations, HMO. It's going to be important to know what an HMO is. Provider-sponsored organizations. That's going to be important to know. And preferred provider organizations, PPO. Other certified public or private coordinated care plans and entities that meet the approved required standards. The Medicare Part C program has rather complex financing depending upon which plan is chosen. Basically, the funding for the Medicare Advantage program comes from the HI and the SMI trust funds in proportion to the relative weights of HI and SMI benefits to the total benefits paid by the Medicare program. For Part C, the beneficiary's payment share is based upon the cost-sharing structure at the specific Medicare Advantage plans selected by the beneficiary, as each plan has its own requirements. For Plan C, payments to the Medicare Advantage plans are based on a blend of local and national capitated rates. Actual payments to plans vary based on characteristics of the enrolled population. Medicare Managed Care. Managed care plans functions on a basis different from regular fee-for-service plans covered under Medicare. Under managed care plans, the Medicare beneficiary selects a specific HMO or other approved plans within a service area for comprehensive healthcare services. It is central to the managed care concept that is selected plan coordinates all of the healthcare services for that person. Managed care plans function on a financial basis that is different from the traditional fee-for-service reimbursement to healthcare providers. Managed care plans receive a per-person payment for Medicare that is predetermined, based on a formula that is established by law and the demographic characteristics of the Medicare beneficiaries enrolled in their plan. Generally, this is a percentage of the average adjusted cost per person for the respective region of the country. So, I see a lot of managed care. Managed care is sometimes known as MC. But the thing that I see a lot about managed care is that they have a special formulary for those members or patients. Some managed care, they cover certain brand names, certain generic names, and so if a member's wanting the brand over the generic, they're not going to be able to if their managed care plan doesn't allow it. In addition to the regular services covered under Medicare, the managed care plans often cover services such as preventative care, prescription drugs, eyeglasses, dental care, or hearing aids. Electing to participate in a managed care plan may also serve as an alternative to purchasing Medigap insurance. Although there are certain restrictions, limitations, and differences from the fee-for-service plans, the managed care plan's fixed monthly premiums and cost-sharing structure help to provide more predictability of out-of-pocket costs for the beneficiaries who do not have Medigap insurance. For Parts A and B, beneficiaries are responsible for charges not covered by the Medicare program and for various cost-sharing aspects of both HI and SMI. These liabilities may be paid by the Medicare beneficiaries, by a third party such as a private Medigap insurance purchased by the Medicare beneficiary, or 3, by Medicaid. If the person is eligible, the term Medigap is used to mean private health insurance that within the limits pays most of the healthcare services charges not covered by Parts A or B of Medicare. So it's kind of like gap insurance for your vehicle. I'm not sure if you've heard of it or if you know anything about it, but sometimes when you buy a new vehicle or you finance a new vehicle, you have to get gap insurance. And what happens with that is if you get in an accident that totals the car, you're still going to owe, I don't know, we'll say $10,000 on the car. Well, you're not going to want to pay $10,000 for that. And so you have gap insurance that covers the $10,000. And so basically, if you break the car or it gets in an accident, it's covered. So Medigap is basically just covers the differences that Parts A and B do not cover. These policies, which must meet federally imposed standards, are offered by Blue Cross and Blue Shield and various commercial health insurance companies. All right, Medicaid. Medicaid is the largest source of funding for the medical and health-related services for America's poorest people. In 2000, it provided health care assistance to more than 35.6 million persons at a cost of $210.8 billion. Billions with a B. Title. All right, here's a quick review. What number is that? Title 19 of the Social Security Act is a federal state matching entitlement program that pays for medical assistance for certain vulnerable and needy individuals and families with low incomes and insurances. All right, so that's going to be aid. So if you aid someone, a lot of the aid, like, when the U.S. aids another country, it's because that they are a low income country and low in resources. So that's how I remember Medicaid. Within broad national guidelines established by federal statutes, regulations, and policies, each state establishes its own eligibility standards, determine the type, amount, duration, and scope of services, sets the rate of payment for services, and administers its own program. So Medicaid is going from state to state, not federal, whereas Medicare is federal over the whole nation. All right, so Medicaid policies for eligibility services and payment are complex and vary considerably even among similarly sized and or adjacent states. Thus, a person who is eligible for Medicaid in one state might not be eligible in another state, and the services provided by one state might differ considerably in amount, duration, or scope from services provided in a similar or neighboring state. In addition, Medicaid eligibility and or services within a state can change during the year. Medicaid does not provide medical assistance for all poor persons. Even under the broadest provisions of the federal statute, Medicaid does not provide health care services even for very poor persons unless they are in one of the designated groups. Of these designations, low income is only one test for Medicaid eligibility for those within these groups. Their resources are also tested against the threshold levels as determined by each state within federal guidelines. States generally have broad discretion in determining which groups their Medicaid program will cover and the financial criteria for Medicaid eligibility. Coverage under Medicaid. The Medicaid program allows considerable flexibility. However, some federal requirements are mandatory if federal matching funds are to be received. A state's Medicaid program must offer medical assistance for certain basic services to most categorically needy populations. Within broad federal guidelines and certain limitations, states determine the amount and duration of services offered under the Medicaid programs. States may limit, for example, the number of days of hospital care or the number of physician visits covered. Two restrictions apply. Limits must result in a sufficient level of services to reasonably achieve the purpose of the benefits. Limits on benefits may not discriminate among beneficiaries based on medical diagnosis or conditions. With some exceptions, a state's Medicaid plan must allow recipients to have some informed choice among participation providers of health care and to receive quality care that is appropriate and timely. Medicaid recipients are required to pay relatively small average expenditures each year. The program provides coverage for almost 17 million children who otherwise would receive little or no medical care. The data for 2000 indicates that Medicaid payments for services for these children, who constitute over 46% of all Medicaid recipients, averaged only a little over $1,000 per child. There are, however, certain other specific groups for whom Medicaid is at least as essential. Those comprising far fewer persons, but who have much larger per-person expenditures. The Medicaid program pays for almost 45% of the total cost of care for persons using nursing home facilities or home health services in the U.S. The data for 2000 shows us that Medicaid payments for these services totaled $51.8 billion. The 2000 payments for healthcare services for over 35 million of Medicaid recipients averaged $5,921 in healthcare expenditures. Medicaid managed care. A significant development in Medicaid is the growth of managed care as an alternative service to the traditional fee-for-service system. Under managed care systems, health maintenance organizations, again we see that HMO, prepaid health plans, PHPs, or comparable entities agree to provide a specific set of services to Medicaid enrollees, usually in return for a predetermined periodic payment per enrollee. Medicaid managed care programs are growing rapidly. The number of Medicare beneficiaries who are now enrolled in some managed care program continues to increase and may soon approach 50% of all Medicaid enrollees. Several states have converted their entire Medicaid programs into managed care. The HMO is the most common MCO. There are various types of healthcare maintenance organizations such as the Staff, Group Practice, Network Independence Practice Association, IPA, and direct contract models. These models are differentiated by how the HMO is linked to the provider organizations, PPOs, which differ from HMOs by their provision services. And you can see page 211 in the manual that goes over HMO models. Types of managed care organizations. Other types of managed care organizations are points of service health maintenance organizations, POS, HMOs, which are hybrid of PPOs and HMOs. POS plan. Members can obtain care through an HMO provider network for the lowest out-of-pocket costs. If members wish to access the larger PPO network, they are required to pay higher out-of-pocket costs. Other type of MCOs are the exclusive provider organizations, which are similar to PPOs but require members to access only contracted providers, and the physician hospital organizations, which are healthcare delivery system jointly owned by hospitals and the affiliated physicians. To complicate matters further, in practice, these are not discrete models but mixed models, with organization offering a combination of the above managed care options. Trends in managed care enrollment. Both the public and private sectors have adopted the managed care trend largely in response to the need to contain rising healthcare costs. Employees covered by managed care accounted for 89% of all insured workers in 1998, up from 53% in 1993. When offered a choice of managed care plans, employees are moving away from health maintenance organizations to less restrictive plans such as point of service services, plans, and preferred provider organizations. In 2002, 107.6 million people were enrolled in PPOs as compared to the 74.2 million HMOs. All right, technology and automation. The world of pharmacy is in the midst of significant change as more pharmacists are attempting to shift from traditional distribution-oriented practices to more patient-focused clinical pharmacy services. To accomplish this change, it will be necessary for pharmacists to move to more a management role with the medication distribution system. Duties previously performed by pharmacists will require delegation to both technicians and technology. This ongoing change in the profession will bring about significant and important changes in the roles that technicians play in day-to-day pharmacy operations, including an increase in the workload and responsibilities for processing prescriptions. Now, I can attest to this, that as time goes on, the pharmacists are going to try to work more on doing things and having duties that focus on the needs of the patient, whereas a lot of the what is the word they say? A lot of the duties will now be delegated to pharmacy technicians. So there's definitely been more and more growth of the responsibility of pharmacy technicians. So legal requirements for pharmacists will still be in place, but in many states, the final inspection of a finished prescription will be the only requirement for pharmacists' involvement in the distribution process. In addition to the processing of prescriptions, technicians will be required to assist in the technician work of generating purchase orders and maintaining inventory, entering and maintaining databases. For example, new medication, insurance information, and performing workload statistics. While pharmacists are venturing into roles that have them involved in more direct patient interaction, prescription volumes are continuing to increase nationwide. At the same time, new medications are being introduced at an alarming rate. These changes in the profession and in the environment in which it is practiced increase the potential for medication errors to occur. Opportunities exist for the technicians to play a key role in ensuring increased patient safety. One way for technicians to aid the patient safety is to become actively involved in a more efficient and effective drug distribution process. Many technologies exist to improve this drug distribution process. Technologies impact the work of humans either by replacing repetitive and tedious tasks or enhancing the ability of humans to perform work.